Okay. All right, now let's talk about this last section today, which is immune dysfunction. Now what I'll do is I'll take the musculocutaneous section, I'll dictate it in later on this afternoon, and then I'll have Megan post it by tomorrow, okay, or later on this afternoon, hopefully. And this will be on your test, all this stuff, okay? So this was a micro test. Okay, your test is next week, right? Okay, so then after that we start trauma, which is my fun part. I like trauma. I try to teach you guys that. The only thing I added on to trauma was chapter 17B, which is hemostasis. I'm going to put that into the trauma component, which is not on there yet. So if you're looking for it, it's going to be there eventually. Okay. As for immune dysfunction, most of us really don't understand how the immune system works. Okay. So instead, I'm going to sort of tell you a story. Okay. I'm going to tell you a story about an analogy. Okay. Basically, your immune system is like a giant army. It's a giant army that protects you against foreign invaders. The number one cell function in your immune system that gets exposed, it's like the guard that's always at the border waiting for that invasion to come, is the phagocytes, which is the macrophages. Those are the first cells that are really exposed to viruses, bacteria, fungi. Okay? And they're excited by cells that are becoming injured. Sometimes macrophages will just encounter bacteria that are in the bloodstream, and they immediately eat them and at that point kill them. But what's interesting about macrophages is then they immediately send for help. Okay? And the first person it sends help to is all that information that they've developed about eating that bacteria, virus, or whatever, a fungus, is it gives a chemical signature equivalent to what's called Army intelligence, telling you exactly what's wrong with that's invading. Okay? And it sends that signal to like an AWACS, an aircraft that carries that information and then processes and gives it out. Okay? And that AWACS is called a T helper cell. Okay? It's a specialized cell that its job is basically to receive these signals of information and then enhance your immune system. Okay? So T helpers then activate things called plasma cells or B cells. B cells can do two things. They can either produce memory cells, which means that your immune system now has a memory and recollection of the disease process. So when you're re-exposed to it, the immune system can fight that infection very rapidly, not have to delay treatment. The other thing that these plasma cells will do, or B cells will do, is that they will produce antibodies. And antibodies are very specific to the disease process. The antibodies are basically small protein, well, not real small, but they're proteins that are made, immunoglobulins, that are made to have receptors on them that they can identify the infection. And as soon as they get secreted into the bloodstream and they start going all over the body looking for this stuff, as soon as it binds to it, to the virus or the bacteria or to anything that's infected by that organism within the cells, it signals. It sends like a signal out saying, here it is. And the next thing that comes along is NK cells, which are natural killer cells, as well as T killer cells. There are specialized macrophages and T cells that are just specialized in killing specific immunoglobulin specific cells. Okay, so it's very efficient, the whole system. Now, there's a whole different kinds of cell lines. Most of these cell lines in the immune system originate from the bone marrow. If you're younger, like you're a baby, the other important organ that contains a large amount of this is the actual thymus gland. By the time you become an adult, the thymus gland usually disappears, and it's only found as this remnant organ that's basically looks like scar tissue inside your chest. So when we do open heart surgery and open up the chest, the thymus gland is right in front of us, and we don't even see it because it's just literally that small. But if you open up a chest on a kid, you'll find out that the thymus gland is sitting right above the heart. So it's not a small structure in a child. Now, the thymus gland is responsible for basically producing a large amount of memory cells. Okay? T for T helper, then activates plasma cells or beta cells that produce a huge amount of memory cells. So it makes kind of sense if your thymus is early on and it's well developed, it then sends now all these memory cells that are processed or information is given to you by your mom through breast milk. Then the thymus gland then uses that as its new encoding for its memory cells. You don't provide the baby with breast milk, then all the mom's immunoglobulins with all the history of what she's been infected with goes to the wayside, and the baby has to be now is basically going into a world unprotected. Okay, so in that sense, it's not a good thing. There's different kinds of macrophages which you'll show you. They're called eosinophils, basophils, and some of these are specialized in producing different things. Some of them help prevent infections in the lung. Other ones are helpful in producing specialized chemicals, mediators such as histamine, which when used appropriately are good because they increase the amount of white cells into that area. But when given too much intravascular or too much release of histamine can cause anaphylactic or anaphylaxatory-like reactions. It shows you how all the lymphoid tissue that's around your body, your whole system is set up to basically protect you. The lymph nodes and the spleen are all part of the immune system to help protect you against any forms of infection. Even inside the liver, you have specialized cells that are basically helpful in removing, which are specialized macrophages that remove bacteria out of the portal circulation called Kupffer cells. So even though the liver is not mentioned as lymphoid tissue, in a way, if you look at the cellular component of the Kupffer cells. The lymph node is a very nice little node that allows lymphatic fluid to drain out. Lymphatic fluid, of course, can contain high amounts of bacteria and infected tissue, and you wouldn't want that to get back into your thoracic duct or back into your circulation. So the lymph nodes basically have very high concentrations of lymphoid tissue, which basically clean this lymphatic fluid before it gets back into your bloodstream. So it's another way of actually cleaning out bacteria. Okay? What you see with anybody who has an infection is that these lymph nodes will develop hyperplasia, and the lymph nodes will become enlarged and painful on touching. It's an inflammatory mediated response due to ongoing infection a lot of times. The actual phagocytes, which are different forms of macrophages, can go all the way from the activated macrophage to your inactivated monocyte. You can have dendritic cells, which are, of course, found in the brain, that are also important as the blood-brain barrier. They also act as phagocytes to clean up the mess. Neutrophils, basophils, mast cells, and eosinophils. Those are all forms of phagocytes that have their white cells basically of different kinds of functions. Phagocytes, the way they live normally is they stay in your bloodstream. When they're needed, then they become activated and they develop what's called podocytosis, which they they marginate first, which means they begin to adhere to the vascular wall, and then they develop feet, which is called podocytes, or also in some books called diapedesis, which allows the macrophage to actually walk itself through on the cell wall, the endovascular endothelium. The reason histamine is so useful is that it loosens up these tight junctions and lets the macrophages in. That's what the purpose of the actual histamine release. So there is a good reason for it. The problem is that if you cause massive vascular release like that, you get massive amounts of fluid loss and severe hypotension because of it. Eventually, you get exudation into the inflamed tissue by these white cells, where they can begin to mop up and clean up the actual infection. What actually triggers them is things that are chemical mediators called chemotaxis. These are chemotactic substances that are produced by inflamed or injured cells. So they're trying to tell, hey, look, the body, I'm willing to die to give myself up. I got an infection here, and you got to get rid of this. And it's a very communal kind of system that the many is not as important as the one. Eventually, you have specialized systems that the macrophages uses, including opsonization and phagocytosis. Phagocytosis means that the actual macrophage surrounds the organism and completely ingests it when it incorporates lysosomal structures to break down the bacteria. Opsonins are specialized structures that bind to the bacterial cell wall, the viral cell wall, and it causes complement activation, eventually destruction of the cell wall, which perforates holes into it and kills the organism, which makes the phagocytosis more efficient. What you're looking at is, this is kind of a nice little drawing showing you what activation comes in. You got your T helpers come in, and then says the B cell, hey, activate, and it forms into activated forms of either plasma cells or memory cells. The plasma cells are what eventually produces your high levels of antibodies, okay, which are then they attack the bacteria individually, and then with the activation of the actual antibodies, then the actual white cells can come in and clean up the mess. So memory cells are very important because they retain the memory activation. Once they get re-exposed to that same antigen, it immediately reactivates and produces high amounts of antibodies. You actually, when you activate a plasma cell to produce antibodies, you can produce as much as 200,000 antibodies per hour. It's a large amount. Okay, so your body becomes pretty much highly invested with these antibodies to basically break infection. The other thing that also produced by different kinds of cells besides these, which are mostly macrophages, are pyrogens, which is going to produce fever. Fever is actually good, okay, because it kills bacteria. Okay, high elevations in temperature are usually not good for those bacteria that are in you. Your body, your eukaryote cells are a little bit more tougher than the bacteria. As a consequence, it can tolerate elevations in temperature a little bit easier than the bacteria, which makes them more easier to kill. So, driving their fever down is maybe not such a wise thing. You get T cell development in the thymus, which eventually forms memory cells and all that stuff. I'm not going to go into all the specifics. You can spend hours on this alone. We just know that the thymus, the job basically is to produce long-term T helper cells and T memory cells, which are the beta cells that are producing memory cells. Beta cell development, that's what I just eventually showed you, eventually produces either immunoglobulins or produces memory cells. The other thing that you can have is you can have some kinds of bacteria that have specific cell wall receptors, which we call antigens. These antigens will then react, cause the lymphoid tissue to react and attack immediately. It identifies them as not itself. Unfortunately, antigen presentation could be an organ transplant that you just put in an individual. The body will begin to attack it, even though it's going to do it good, but the antigen is foreign to it. As a consequence, the body begins to believe it's an enemy, even though it may be useful. The antigen response either could be activation of B cells, which eventually forms immunoglobulins. You can actually cause activation of natural killer cells, which then they attack that cell immediately via a whole host of mechanisms. And then you have your helper T cells, which then can cause propagation of the B cells to increase memory production as well as production of increased levels of antibodies. Which is what we do basically when we immunocompromise patients for organ transplantation. We're suppressing all these natural mechanisms so antigen receptor recognition can go away. Eventually, lymphocyte development and maturation is a whole host of process that usually takes place inside the bone marrow. Unfortunately, some of these bone cancers can develop from pluripotential cells and cause disease, and basically by destroying the actual natural matrix of the bone marrow inside the bone. T cells can be either cytotoxic T cells, which means they're killer cells. So you can see how they can become activated, and you can see the actual nature of the cytoplasm changes as their enzyme value of these lysosomal enzymes increase dramatically in these individuals, versus a normal resting helper T cell. It's just sort of sitting around waiting for the signal. Remember, I told you it was the activation of phagocytes and the macrophages that sends these guys the information, and then decide, should I activate and send information on to other cells. So T helper cells are critical for really, if you have an infection, to stop it from progressing. There's also regulatory T cells that actually are involved in chemical mediation, and you could sit here and talk about this regulatory T cells for the rest of the day, so I'm not going to go into that, but Just know that it's a very complex mechanism. I just want you to get the basics first. Cytotoxic T cell activation is the natural killer cells or the T killer cells that are activated after exposure, usually to the actual bacteria or the virus. And then you get activation via immunoglobulins, which then makes these cells be site-specific. Natural killer cells are very dangerous because of their high enzyme count. If they attack a normal cell, they would rapidly destroy it. So the body has a very tight control of these cytotoxic T cells. It only activates them when they're specifically activated by usually immunoglobulins or antigen-specific that it knows is foreign. The killer cells target the cell and causes its destruction. What you see is once they bind to the cell wall, they release the actual granules and kill it. In the process, it kills both itself and the cell. Okay, so target cells, killer cells end up killing themselves in the end. If you look at pus, at purulence under a microscope, it's cellular debris. It's these killer cells that are involved in it that causes the pus. It's basically degradation of cells into this kind of matrix that looks white. Okay? That means the body's doing its job of fighting infection. The activation of T cells, the helper cells, is I just talked to you about before. I'm not going to go into it. This is this nice picture. If you want to go through that as well, if you just remember the story I told you, it's exposed to antigens that are processed usually by phagocytes, and then it goes from that information to activate beta cells, which then form memory cells or the actual antibodies. Activation of B cells to make antibody is done by the T helper cells. Without the presence of T helper cells, the beta cells won't do anything. They'll just sit there. That's why if you have HIV, wipes out T helpers. Okay, if it wipes out your T helpers, then the beta cells are just sitting there saying, "What's up? I know there's an infection going on here, but I can't do anything because I can't get activated because I'm lacking the T helpers." So once the T helper value becomes significantly low, then the immune system becomes significantly suppressed, and then if opportunistic infections take over, things that normally the B cells would be very easy to take care of using their antibody levels can't do their job. Okay. Now there's also B cells can become activated in certain kinds of cancers like multiple myeloma. Multiple myeloma, which I'll show you later on, is a cancer of B cells, okay, where it produces high amounts of these antibodies, which then kills the kidneys, but it also infiltrates bone marrow and causes severe microfractures, and it's a nasty disease. Again, this is all the mediators. You can go into it if you want to. I'm just giving you, again, an overview of what it's for. One of the things that you have to understand is that the initial inflammatory response that is activated by tissue damage eventually leads to activation of certain kinds of chemical mediators that allow phagocytosis to take place. As you can see in this nice picture, how they marginate and eventually get into the area and basically help clean up the bacteria. So these are chemical signals that are being sent downstream into the blood vasculature to cause the plasma cells, activate the white cells to basically marginate and get into the tissue to cause a repair and basically the cleanup of the bacteria. The immune system is, again, a complex mechanism of multiple layers of different things to try to protect your body from opportunistic infections. This kind of table is kind of nice because it sort of gives you a breakdown of the different components. So if you have time, it's sometimes helpful to use that for testing. Immunoglobulins are not just one type. There's many different kinds. They're usually, depending on what they're used for, IgA is usually is heavily concentrated in secretions, so it's found usually on linings of pulmonary linings, mucous membranes, and it basically acts as a topical defense mechanism. IgG molecules are more defense against infection. They tend to be a much bigger molecule than IgA, but the really big one's IgM. IgM actually causes lysis of the bacterial cell walls. If you see somebody with conferred IgM levels that are elevated, that usually confers immune protection for that individual. IgG is usually the first line of defense in the bloodstream for infection. Usually IgG levels will go down after the acute infection, and IgM levels stay at an elevated level for prolonged periods of time. There's also IgE. IgE are also antibodies. These are antigen specific, okay, and they're usually bound to mast cells. So if you have an antigen that binds to the IgE, it then causes mast cell degranulation, which causes the release of SRS, which is slow-releasing substance in anaphylaxis. Also have histamine, bradykinin, a whole set of interleukins, thromboxanes, all get released by IgE activation. And what that leads to is an anaphylactic reaction as a consequence, which is, can be deleterious depending on the situation you're in. These are the different immunoglobulins and actually how they look. You can see the IgM is a huge molecule, and that's what gives it its ability to bind to a bacterial wall and actually help perforate the wall much more efficiently than IgG. IgG is really kind of nice because it actually binds to this bacterial wall very quickly, much faster than IgMs do, so it sends a very rapid signal transduction to get the white cells to attack that area very, very rapidly. And the IgE is usually found bound directly to basophils and mast cells, which are the ones that release your friends, the histamine. What you see with direct or indirect roles of antibodies, sometimes the actual virus or the toxin will be bound itself, or bacterium will be bound itself by the antibody, causing the white cell to then become activated. It also causes other kinds of complement activation, which are part of the immune system. What I think of complement basically is a giant specialized drill system. What it basically does is as soon as antibodies are activated, the complement cascade gets activated, which then begins to form these specialized proteins that will begin to bore holes through anything that it's attached to. So it doesn't care what it's attached to. If it's whatever it's attached to, it's going to put away a hole through it. It doesn't really care. All it thinks of the world is basically a drill. Everything should be drilled. Build, what is it? What does Sarah Panel say? Drill, baby, drill. That's what cytotoxins do. Okay, what's called complement cascades do. Complements also help identify certain kinds of bacteria and makes the macrophages bound specifically to attack it. So it also acts as a specific signaling device as well. The vasoactive mediators are released by local inflammatory response, such as histamine, or the cause capillary permeability, which is helpful because it increases demargination of white cells. It causes vasodilation, which decreases perfusion velocity, which increases the amount of degranulation that occurs from the white cells, as well as bronchoconstriction may also help. As for leukotrienes, you have capillary permeability is increased, bronchoconstriction, negative inotropy, and coronary vasoconstriction. Those are bad signs, but those things are also vasoactive mediators that are being released by things like mast cells and your actual certain activated cells by IgE. Prostaglandins may also be released, eosinophil chemotactic factors, all these things. You don't have to memorize this stuff. I think it's silly. I just want you to realize that there's a whole host of basically chemical mediators that are being released under certain kinds of situations. Histamine is specifically the one that you need to care about a lot because that's a lot of our drugs will cause an anaphylactoid-like reaction. If you give somebody high levels of morphine, although it's rare, but if you give high enough levels of morphine, it acts like an anaphylactoid-like reaction, causing histamine release from cells, and it causes, as a consequence, vasodilation, and it causes hypotension in some individuals. As you also have other kinds of pathways that are also important as part of the immune system response, which is the arachidonic acid pathways, which eventually form cyclooxygenase and lipoxygenase, and form these different compounds that cause your normal inflammatory mediated cascade. The kinin cascade is also one of those as well, which eventually produces bradykinin, which ends up being a vasodilator with the increased vascular permeability, and also increases the level of pain. That's why we trying to find some ways of actually inhibiting this mechanism to try to decrease the pain activation from it. which also enhances it, which is kind of good. I mean, if you think about inflammation, is if you're painful, what are you likely to do with that piece of if your extremity is hurting, what you're likely to do? You're likely to rest it and not bounce it around and get more secondary injury to it. So, in essence, it protects you. The downside to it is inappropriate at times if you're doing surgical incisions, then you know it's going to hurt, so what's the point? You already know it should stay still, and you keep the person limited in their exercise at that point. The complement cascade is basically the drill baby drill system. You can memorize all this if you want to, not. You'll remember it in 3 days, so I don't make you memorize stuff like that. Just know that anytime you see C attached to it, it's a complement cascade. It's a protein structure that basically helps put a hole into anything that it touches. And this is the actual, very uncomplicated. When you do research in this area, which I've had friends of mine that were doing this kind of research, some more people were interested in, especially surgical residents were interested in this, because of the coagulation cascade and inflammatory immediate response. And especially when we were first working on sepsis and stuff, we would actually sit down and draw all this stuff out. It must be about maybe another 40 or 50 more components to this that are not on this drawing that I can tell you off the top of my head. But it's something that you don't have to worry about, and just know that it's a giant cascade with a whole host of effects. Once you activate one, you cause an activation in the other. The body's trying to basically cause an inflammatory immediate reaction to try to heal that tissue and destroy all the surrounding bacteria and all the damaged tissue. Complement disorders can be actually very significant. I saw this about a year ago. This is a patient that looks normal, and you can see what happens when you get complement hereditary angioedema activation. The lips start becoming greatly enlarged, and it can become a hugely problem with airway. It's an autosomal dominant dysfunction of C1 esterase inhibition. So these people are missing a C1 esterase inhibitor, so they get complement overactivation. Okay, and as a consequence, all this where the blood flow is going in high amounts, which is in your mouth, it starts causing damage to the cell wall, and it starts causing this hereditary angioedema to develop. Okay, so this can become an emergency airway in a hurry. This is not treatable by antihistamines or by epinephrine. Racemic epinephrine does not work on this. Okay, epinephrine does not work because it's not a disease process of epinephrine. It's not a histamine release. It's a C1 esterase inhibitor of failure. Okay, so what you do is you give this person a C1 esterase inhibitor as a treatment of choice. Although I've never seen that drug, I can't remember the name right now, but it's very expensive. So it's very hard to find. Instead, what we usually do is give FFP. And that's what we did to this lady. We gave her FFP, and all of a sudden she got better. FFP has C1 esterase in it, so it's in that sense it works. This is what it actually will look like. Okay, you can imagine the airway getting to be a nightmare like this. You can see in the second picture the uvula is grossly distended. Okay, and it's now laying on top of the tongue. Okay, this person could have this hereditary angioedema. Okay, so you got to be noted. I got called on this about a year ago as well as another patient. This one we did. This was very similar to the lady went from looking like this to this in radiology suite on exposure to certain of the radio contrast dye. So it can be activated by different things. And the second case, which is this one here, was actually a child that was complained after surgery that his uvula was touching his tongue. When we got called, it was because it was supposedly anesthesia that caused traumatic injury of it. And guess what? We didn't even intubate the kid. Okay, so that was kind of the tip-off that something else was going on. And found out, we sort of said, well, you know, I inferred to them, said, you ever heard of hereditary angioedema? And apparently the family had a history of it. So they sent the kid for it, and guess what? He has the same thing. So you also can get allergic reactions. Allergic reactions are from anaphylaxis. You can get, and that's the one. There's two kinds of allergic reactions that you hear about: anaphylactoid and anaphylaxis. Anaphylaxis is a truly IgE-mediated reaction. Okay, that means that person has to be priorly exposed to something. Okay? If you've never been bit by a bee, are you going to be likely to become to get an anaphylactic reaction to the bee? The answer is no. Unless you've been bitten by a bee before, then you get the IgE-mediated reaction then, okay, in previous exposure. Some people, like myself, were really kind of silly. When I was about 7 years old, I decided to see what wasps were going in and out of this hole. So I put my hand into the hole to figure out why the wasps were flying in and out. I wanted to see. And I pulled out their nests. They weren't real happy with me, so I got hit about 15 times. So I learned real fast to let that go. But after that, I still kept playing with bees. So every once in a while, I get bit by bees quite often, unfortunately, at my house. So I have never had a reaction to it. So, you know, some people develop more of a tolerance to it. Other people, once they've been bit one time, if they develop IgE-mediated hyperactivity, the next time they get bit, it's almost lethal. Okay? The same thing happens with antibiotics. If you have an IgE-mediated antibiotic reaction to it, if the next time you get exposure, you'll only give maybe, you know, some people tell you, just give 1 cc of the actual NSAID, you'll be fine. No, it won't be fine. If you give 1 cc of anything to anybody, if they have prior exposure to the stuff and they had an anaphylactic reaction, it's only going to get worse the second time around. Okay, and we found that out several times the hard way. So just be careful of that. That's why we pay attention to this. This is a lecture, but it's really significant to what you do. Allergic reactions are also associated with people that have asthma, history of rhinitis, which is, you know, inflammation of the nose. If you hear somebody that has asthma, it has nasal polyps, and is allergic to aspirin, those people are really much more likely to have anaphylactic-like reactions when you put them under anesthesia. There's lots of people with food allergens, unfortunately, especially to peanuts. If you develop latex allergies, what you'll end up being allergic to is anything that has latex-like kind of substance on it. So people that are latex allergic will end up becoming banana allergic. People will become also allergic to mango. Okay, so you want to sort of avoid those if you become latex sensitized. Drug allergies, of course, something hopefully you get exposed to, but then you get re-exposure. Heparin is a kind of a drug-induced allergy that develops what's called HIT syndrome, which is that you get the platelet count becomes significantly diminished, and the whites and the red blood cells actually begin to stack together and form microembolic phenomenon in that individual. It's called also white clot syndrome. Allergies, this is the IgE mediated. You can see that IgE, once activated by the plasma cell, that releases IgE, which then binds to plasma cells, and then these plasma cells, as soon as the antigen touches them, it releases the mediators, which then causes the symptoms. This is a type 1 hypersensitivity reaction that we see. Okay, so ultimately you need the IgE mediated reaction to cause the effect. These kind of mediators, of course, increase the release of histamine, SRS, and much other stuff, and can cause significant anaphylactic-like symptoms. So let me just keep going. This is the activation. This is a nice picture showing you all the stuff that's being released. Again, more stuff that's being released. I'm not going to go into specifics. I'm just going to keep moving. Allergic reactions anaphylaxis is life-threatening. Okay, the primary exposure gives you sensitization, and the secondary exposure is what ends up killing you, not the first time around. So the second time exposure is what ends up killing you. What you see with these kind of people is you get angioedema, you get conjunctival edema as well. They get laryngeal edema, urticaria. Bronchospasm can be very severe if you get into cardiac arrhythmias. I've seen 3 people die from severe type 1 reactions. And it's very, it's very demoralizing because you get down there. Usually they call you when they can't intubate, and by that point the larynx is completely closed. You'll get somebody like this. This is immediate treatment is epinephrine. There is no other antihistamines at this point. You're wasting your time. Please don't do that. Give the person epinephrine. Don't overdo it, but just give them epinephrine. This one tends to reverse this, and this is what ends up happening. Okay, this is somebody who died. Their larynx is completely closed. You cannot put an endotracheal tube through that. So the only thing you can do is do a cricothyroidotomy or tracheostomy to keep that person alive. So not good. Anaphylaxis is caused mast cell degranulation, and it causes capillary permeability problems, hypotension, bronchoconstriction, cardiopulmonary collapse. The immediate treatment is oxygen therapy, IV fluids. Epinephrine should be first considered very quickly, H1 antagonists, and steroids for long term. Because there's two levels of anaphylactic reaction, the primary and the secondary. The primary you have to treat with epinephrine, but the secondary response is not really well treated with epinephrine. Instead, it's better treated with steroids to immunosuppress that individual. So usually what we do is we give 1 to 2 grams of solumedrol, grams, not 100 milligrams. We're giving a gram, okay, to knock it down so you don't get the secondary response activation. It does not do anything for you in the acute stage, but it helps you in the secondary stage. Now, how do you give epinephrine? Okay, you can give it IV, I give it IM, or you can give it sub-Q. The real cons about giving it sub-Q is it can cause necrosis of the skin. So most of us will give it IM or IV. Okay, the problem with IV, it depends on muscle mass and a bunch of other variables. You get to variable concentration. So if you have somebody who's acutely ill and you don't have an IV access, IM is a perfect choice. Secondary is getting your IV started and then giving IV medications. But, one thing we tell you about, okay, how do we dose this? It's not a big deal, right? And what ends up happening is if you give people IV medications of epinephrine, you can kill them from it, okay, if you're not careful. So you've got to learn how to use the medication. So I think that's an appropriate part of this discussion. You can read this on your own. This shows you all the cons and pros as to why you do it. The pros is that it immediately gets to the bloodstream, and it's a much more rapid response. The downside to it is you can overdo it and really hurt somebody and basically ingest, and compared to read all this part too. So how do you dose it? Okay, what you do is you get a 1 to 1,000 concentration of the drug, and you give 0.01 milligrams per kilograms IM. Okay, the normal maximum you ever have to give an adult IM is 0.5 milligrams, and in a child usually it's around 0.3 milligrams. Okay, the best way of doing this IM-wise is an EpiPen. Okay, an EpiPen will come right there. It tells you the concentration. In this case, it's 0.3 milligrams on this box, which is appropriate for a child. You open it up, you break the seal on it, and then you turn it and you release the activator button, which is what this is doing. And then what you do is you bury it laterally into the thigh. You don't bury it in the front, which is what a lot of people do. If you bury it in the front, you hit the femoral artery in the process. It's not going to be good. Okay, so you want to bury it laterally like this. It's over here, this lateral quadrant. Okay, you bury it and twist. Okay, when you twist, the needle will spring out and inject. Okay, a lot of people will hit it and then they pull it back, and then the medication sprays all over the place. Okay, you got to hit it, rotate it, and then hold it for 10 seconds. Okay, that way it fully gets into the body. And EpiPens can be life savings to individuals. And if you don't know how to give it, and you see a kid's down and they know they have an EpiPen, but nobody knows how to use it, it's useless. Okay, so at least hopefully you'll remember this part of the lecture, how to properly use it, to make sure that you leave the needle in the person for about 10 seconds so it has its full effect. Most kids are going to be screaming pretty much at that point. Okay, and it doesn't really matter. When you hit them with the EpiPen, you got to sit on them so they don't move. You just do it. Okay, because once you get them over it, they get better pretty quick. If you get into a state where the person goes into shock, but still has a blood pressure that you can palpate, please do not give a milligram of Epi. It's a good way to kill them. Okay, if you give somebody a milligram of Epi, the still got a blood pressure. The next blood pressure will be 350, and you'll blow out their brains by having a big CVA on your hands. Okay, and that's what ends up happening. That's why Epi's got such a bad rap, because the blood pressure rises so fast. Instead, what you take is you take 1 cc of it and you dilute it out, which is 100 mics, okay, which is 0.1 milligrams, and you dilute it out in 10 cc's, which brings it down to 10 mics per cc. So if you've got a blood pressure, give 10 mics at a time till you see the person respond. Okay? I've seen people that have become very difficult to respond, and I've given up to 1 milligram slowly until you get the response you get. Okay? So I've done that. Okay? But just go slow. Okay? And you got 10 or 15 minutes here. It's not, unless somebody's dying acutely on you, then they're going to go into full cardiopulmonary arrest pretty soon anyways. Then you can give them the milligram of epi at that point. But most of the time, hopefully, if you have a blood pressure and the person's still awake and talking to you, then you don't need to hit them with so much. Okay? They will respond once you get the IV epinephrine in them. Okay? The reason that we give such a high dose of 1 milligram IV-wise is when you go into full cardiopulmonary arrest, by the time it circulates, it breaks down so much in the lung that it doesn't really get systemically as much. So you don't get the severe hypertension that you'd expect. But all of you have given people epinephrine in codes, and you've had blood pressures of 250 after the code. But imagine having a blood pressure of 350 and higher, and that's scary. So be careful with this stuff. Then you also have what's called anaphylactoid reactions. These are non-IgE mediated, which means that they have no prior exposure. The problem with these kind of diseases is that you don't have any clue when it's going to happen. You can give them a brand new drug they've never been exposed to before and all of a sudden get an anaphylactoid reaction. So they have no prior anesthetic history, and you give them this stuff, and all of a sudden they get a reaction that's very clinically similar to anaphylaxis. So it does not need prior sensitization. It does cause degranulation and releases of the vasoactive mediators, will lead to hypotension and cardiovascular response. And basically the treatment is the same. It's still with epinephrine. Type 2 hypersensitivity reaction is also what's called a cytotoxic hypersensitivity. In these individuals, you get antibodies that will be released and cause the actual damage to different components in the body. Antigens are normally endogenous, although exogenous chemicals such as haptens can attach to the cell membrane. It can cause drug-induced hemolytic anemias, granulocytopenias, and thrombocytopenias. They're usually IgG and IgM mediated. The phagocytes and PA cells usually play a very important role of activation in causing the destruction of these different cells. And type 3 hypersensitivity, is it already time? Wow, time flies. Okay, what I'll do is I'll stop here, and I'll tape the rest of it later on and have it for you guys online. Okay, have a nice lunch.